Colleagues, now we are going to resume our master class. Now I request Dr. Apurva Mukherjee, who is one of our course directors to this master class, to introduce today's chairperson, Dr. Vibhuti Saha, and Vibhuti in turn will introduce Subhash, and then actual master class will be started. Thank you.
Good morning, everybody. Good morning, my respected Dean, Dr. Amol Banerjee, and welcome our erudite speaker, Dr. Subhash Todi. And I must be failing in my duties if I do not mention Subhash Todi's contribution in ICU management, which is one of the important subset of critical care management. And today's topic is antibiotic resistance in ICU. So there will be a lot of interest from all the internists all over the state. And I introduce our beloved, respected, well-versed chairperson, Professor Vibhuti Saha. And may I request Professor Vibhuti Saha to introduce our learned speaker, Dr. Subhash Todi, today, and to start the proceedings. Thank you all.
Thank you, Apurvoda, and thanks to Dr. Amol Banerjee. It's my proud privilege to introduce Dr. Subhash Kumar Todi. In fact, Dr. Subhash Todi did his MBBS from Calcutta National Medical College in the same year when I passed MBBS from NRS Medical College, and we had been good friends from the very beginning. Subhash did his MD here, and then he went to US for his trainings. And he is one of the pioneers. I think he's a pioneer of critical care in Kolkata. In fact, he had been doing his good job, great job in developing critical care in Kolkata. And not only in Kolkata, he is a stalwart in critical care in all over India. Currently, he's the director of critical care at AMRI hospitals. So he will be talking to us on multi-antibiotic resistance in ICU. Just to briefly set the ball rolling, we know that though the ICUs, they contribute to about 4 to 5% of the beds of hospitals, they contribute to more than 30% of the infections we come across. And we know people are there with comorbidities, elderly people, post-trauma patients. They are there for a long time. They are exposed to so many devices, the lines, the catheters, the ventilators, and we are using antibiotics many a times without any rationality. So all these contribute to development drug-resistant bugs in the ICUs, which are, we say these are the ICUs are the hotbeds for these drug-resistant bugs. And if you compare with the Western world, we are having more of gram-negative multi-drug resistant organisms. The ESBL, Enterobacteriaceae, the third generation cephalosporin resistant organisms, MDR, Pseudomonas, Acinetobacter, Stenotrophomonas. And we know the antibiotic pipelines have dried out. So we have to have policies and strict antibiotic policies, infection prevention measures, and antimicrobial stewardship. And to tell us about this, Dr. Subhash Todi is the most suitable person. So I request Dr. Subhash Todi to start his talk. Thank you.
Thank you. Thank you, Vibhuti. Let me share my screen. Can you see my screen?
Yes, we can.
Okay. So thank you all. Thank you, Dr. Apurva Mukherjee. Thank you, all the chairpersons. Multi-antibiotic resistance in ICU is a very hot topic. It's a silent epidemic. This is more of an epidemic than COVID. It is killing more people worldwide, and more so in the Asia-Pacific region than anywhere else. As you can see, the projection is more than 47 lakhs people would be dying by 2050 for multi-drug resistant infections. So it's very important we should keep in mind what's going on. So basically, the drug resistance bacteria can be divided into two. One is fermenters, one is non-fermenters. So for postgraduate fermenters, Enterobacteriaceae, E. coli, Klebsiella, and non-fermenters, Acinetobacter and Pseudomonas. And both WHO and the Indian authorities have critical priority of these four bacteria: carba-resistant E. coli, carba-resistant Klebsiella, carba-resistant Acinetobacter, and Pseudomonas. And the reason for this is we are probably leading the world in carba-resistant E. coli, not only in the hospital, but also in the community. As you can see in this world map, we have a very high degree of carba-resistant E. coli, very high degree of carba-resistant Klebsiella. So is carba-resistant Acinetobacter. We are a little fortunate probably with Pseudomonas. In fact, Klebsiella is nowadays known as the new Pseudomonas, but we also have our share of Pseudomonas resistance. So these four killer bugs are the most important bacteria that we have to deal in our everyday practice of multi-drug resistance infection, and that's what I'm going to dwell on. So just to touch a few basics on antibiotic resistance, how do they develop? You know, this is a gram-negative bacteria. It has got a cytoplasmic membrane and a cell wall, and there is a periplasmic space. This is very, very important to know this periplasmic space. I will tell you why. You know, there are porine channels through which the antibiotics would enter. So one can get a mutation in this porine channel. And you see, the mutation in porine channel is very hallmark of imipenem. On the other hand, there are mechanisms of pumping out the antibiotic from the bacteria, what are called efflux mechanisms. Meropenem is a carbapenem, which shares this efflux mechanism. So if you get a culture report sensitive to meropenem, but resistant to imipenem, this is possible. It can have just a porine channel mutation. So it's not a lab error. It is a true physiology that there is a porine channel mutation. So a lot of antibiotics, they share this efflux mechanism. So even if you have a culture sensitivity positive, say sensitive to tetracyclines, but resistant to meropenem, there is a very high likelihood that that gram negative might be resistant to tetracycline, because it is not possible in the lab to know these efflux mechanisms. So porine channel mutation and efflux mechanisms. The others, the most important is the beta-lactamases, which comes into this periplasmic space. There are a host of beta-lactamases that we will discuss. You know, this is the basic difference between gram-negative and gram-positive. The gram-positives do not have this cell wall, and they do not have this periplasmic space. So it is not that gram-positive do not manufacture beta-lactamases, but they are not killed with beta-lactamase inhibitors. We cannot treat Staphylococcus with amoxicillin, clavulanic acid, or some other piperacillin, tazobactam, because the beta-lactam that they produce is going to diffuse in the environment. They are not going to be confined in this periplasmic space. And that is where the beta-lactamase enzymes work. So that's why the beta-lactamase enzymes do not work in the beta-lactams produced by the gram-positive. So gram-positive become resistant by mutation in the cell wall, in the outer membrane, rather than the producing beta-lactamases. So that's very important. There are other mechanisms like target mutations of quinolones. There might be ribosomal mutations, tetracyclines and aminoglycosides, and enzyme targets of trimethoprim and sulfonamides. But the most important is the beta-lactamases. Beta-lactamase enzymes, which circulates in the periplasmic space, and as soon as an antibiotic, you see, most of our antibiotics are beta-lactams. Penicillins, cephalosporins, carbapenems, they are all beta-lactams. As soon as a beta-lactam enters here, the beta-lactamase enzyme will work on this. So this is the basic tenet of antibiotic resistance, and these bacteria are very clever in producing so many of armamentarium to kill this antibiotics. So these are the different beta-lactamases that we should be aware of. Basically, there are serine beta-lactamases and metallo-beta-lactamase. What in our country, what we should be aware of is what is called CTXM, NDM, AMP-C, and OXA. These 4 beta-lactamases are the ones which have almost 90% of most beta-lactamases. CTXM enzyme, if the bacteria has it, then it will be resistant to cephalosporin. It might be sensitive to piptase, but usually it is sensitive to meropenem. NDM, it is resistant to all beta-lactams. AMP-C, it is usually resistant to cephalosporins, piptase, but will be sensitive to carbapenem. OXA will be resistant to carbapenems, cephalosporins, and piptase. So we'll be discussing about these 4 enzymes which you should keep in mind. These are the 4 beta-lactamases which are very important in our country. Now, how do we do the phenotyping? You know, phenotyping is culture and sensitivity. This is the age-old method of disk diffusion. Nowadays, most of the labs, even the secondary care hospitals, will have this automated method of culture and sensitivity where they have the MIC calculation. But the gold standard method is what is called broth microdilution and E-test. Almost none of the standard labs will do this. And that's why there is some problem of interpreting the sensitivity. An antibiotic may be sensitive by disk diffusion or by Vitek, but it may come out to be resistant by these mechanisms. So we'll be discussing these discrepancies. Now, just a few words about MICs. Now, what is an MIC? Basically, this is a serial dilution. And as you can see, the minimum dilution in which the bacterial growth gets inhibited will be the MIC. So in an automated method, this is done inside the machine. And so the MIC of this bacteria would be probably 0.5. And that's how it goes. So one puts a serial dilution, and whenever there is a inhibition of the growth, that is taken as the minimum inhibitory concentration. But that is very characteristic of that particular bacteria in that particular patient. But how do I decide sensitivity and resistance? This is decided by something called breakpoint. These breakpoints are decided universally, and this is an international consensus that, for example, if I take your cefotaxime, if cefotaxime MIC is less than 1, then it is sensitive. More than 4 will be resistant, and in between it is intermediate. So this is cefotaxime against Enterobacteriaceae. Similarly, almost all the antibiotics and all the bacteria, almost all, will have their breakpoints. So once we know the MIC and we have this breakpoint list, we know whether this bacteria is sensitive or resistant to the antibiotic. And that's how these are reported. You get an MIC and you have the breakpoint which is there, which is standardized all across the world. And that's how you report sensitivity and the resistant. Only thing, the MICs are usually done by the Vitek or by the disc diffusion methods. And that's why there might be some problems in interpretation. But this is what is the standard way which we are approaching nowadays. Now coming to this definition of MDR, XDR, PDR bacteria. Now, per definition, an MDR is resistant to at least one agent in 3 or more antimicrobial categories. Very important. These are the antimicrobial categories. So even if you are resistant to one, for example, you are resistant to ceftriaxone, that will be taken as resistant to this group. So if you have 3 or more resistance, if you have ceftriaxone resistant, gentamicin resistant, amoxiclav resistant, that is MDR. So it's very important. You don't have to have, even if you are sensitive to the other cephalosporins, if you are resistant to one cephalosporin, then it is considered as resistant to that group. And the reason is, as I was mentioning, most of this S and R are done by this Vitek or by the disc diffusion. But if you go by the gold standard method, the chances are very high. If it is resistant to one agent, it will be resistant to the others. So that's why the international community has decided the definition of MDR as having at least one agent in 3 or more antimicrobial. And what is XDR? These are usually resistant to all categories, 1 or more agents in all categories, except to at least 1 or 2. So they're still sensitive to all antibiotics in 1 or 2 categories. Then they are XDR. And PDR is resistant to everything, including colistin. So that's how this definition comes. So basically XDR is resistant to at least one antibiotics to all categories, except say if it is sensitive to aminoglycosides. You see amikacin sensitive, genta resistant, it will be taken as resistant. This is resistant. This is sensitive. So I would call this bug as an XDR because it is sensitive to carbapenems, sensitive to colistin, but resistant to the others. That's how MDR, XDRs are defined. So it's very important to, in order to know the epidemiology, that these definitions are applied. So basically in practice, when we come to the bedside, that is what we get. We get these 4 scenarios. We have a bug which is resistant to cephalosporin. We are talking about drug-resistant bacteria, gram-negative, but sensitive to piptase and carba. We have a scenario where it is resistant to cephalosporin and piptase, but sensitive to carba. And the other is resistant to carba, intermediate to colistin. As you know, the sensitivity to colistin has been withdrawn now, and most of the labs will just report it as sensitive, as intermediate. And scenario 4 is resistant to everything. So we have to put our patient's antibiogram into one of these 4 scenarios. So this was phenotype, that is culture, sensitivity, MICs, breakpoints. But nowadays we are going more and more toward genotype. That is, we need to know the resistance mechanisms. And there are many gadgets now in the market which will tell us, you see, within a minute, this is the carba test, which will tell us whether there is an NDM enzyme in this E. coli. They are still a little expensive, but the way these are going will very have a soon affordable genotype gadgets. For example, this multiplex PCR panel, this is very well known from the COVID time. It tells us viruses, it tells us atypical bacteria. The lower panel will tell us 32 bacteria, will tell us whether there are any of these enzymes are there or not, CTXM, NDM, OXA. It will tell us gram-positive resistance. And then it will also tell us atypical and viruses. We have meningitis panel. It doesn't have resistance gene, but we know exactly which bacteria is there. We have the GI panel. Again, we know which viruses or which bacteria is causing the gastroenteritis. and we have blood panels where there are some resistance genes, but we also know exactly which bacteria. And this is done on blood culture. The others are done directly on the specimen. We can send the stool, we can send the nasal swab, we can send the sputum, but here we have to grow in culture and then we do this. But there are other gadgets coming which can do directly, can do the blood PCR. So it's very important that this genotypic mechanism are also be aware of. So basically, this is the background that I have given. I have given you basically the different antibiotic resistance bacteria that we have to face with: E. coli, Klebsiella, Pseudomonas, and Acinetobacter. What are the different resistance genes that we have to cover, and how the MICs are decided, how the sensitivity and resistance patterns are decided. So now, based on this, I will discuss in my coming time the different cases and how do we rationally choose antibiotics. Because one of the best ways to decrease antibiotic resistance is to choose rationally antibiotics for these bacteria. So let's start with this case. A 60-year-old male is admitted with acute pyelo. He is hemodynamically stable, not in shock. His urine culture is showing E. coli, which is resistant to ceftriaxone, but sensitive to piptase and sensitive to meropenem. So now, given that background, what do you think is the resistance mechanism in this patient? Is it CTXM, NDM, OXA? So I think if we can make it a little interactive, it will be good. So if any of the postgraduates or participants wants to pitch in, what do you think is the resistance mechanism? Resistance to ceftriaxone, to cephalosporin, but sensitive to piptase and sensitive to carbapenem. Anyone? Yeah, Priyanka Mandal, what do you think? Kaushik, can they talk or they have to write in the chat?
They can talk, sir.
So yes, please tell me.
Can you unmute him? Can you unmute?
Priyanka, please unmute yourself and please talk.
Beta-lactamase.
Yeah. So which one is? All of them are beta-lactamase except MEC-A. So which beta-lactamase? This is sensitive to meropenem. So it's unlikely to be NDM, unlikely to be OXA. It is either AMC or it is CTXN. AMC won't be sensitive to piperacillin tazobactam. AMC is sensitive to one cephalosporin, which is cefepime. But by and large, this is most likely a CTXN. That is ESBL, but a CTXN. Okay, so that will be our answer to this. Now, which antibiotic would you choose for this patient? Any guesses from the postgraduates? Which antibiotic would you choose? You have a patient with pyelonephritis. This patient has a urine positive for E. coli, and this is the antibiogram. Which antibiotic would you choose? Anyone? Any volunteers? Dr. Priyanka, which one would you choose? Sagnik, yes?
Sir, meropenem.
Meropenem, why not piptase?
Sir, because again,
MIC is sensitive. MIC8 is sensitive. 16 and above are resistant.
But because of the lower MIC of meropenem?
No, that is the thing. You see, say for example, the break point of piptase is 16. So it is half, right? And the break point of meropenem is 1, then it is also half. This 0.5 and 8 never, that is one of the biggest mistake that we do. The lowest MIC doesn't mean 0.5. It is the difference between MIC and break point. If the break point of meropenem to E. coli is 1, then it is equal to piptase, and meropenem have equal sensitivity, you see. So it's very important that you don't go by this 0.5 and 8. You have to know the break points. Unfortunately, the labs do not share, but it is there on the web. You can just print it out, and it is international. The break points are fixed. They don't change. They change only over 10 years or so. So it's not that MIC is more sensitive. So what could be the other reason of choosing meropenem?
Sir, because it is extended beta lactamase.
Yes, but it is sensitive to piptase. It is, you can't use cephalosporin, I agree. It is extended spectrum beta lactamase. Ceftriaxone would fail in this patient. But why not piptase? That's my question. Why can't we use piperacillin tazobactam? Any guesses? There is one chat. Inoculum effect. Inoculum effect is usually severity of infection, and it is more of a lab phenomenon. It is very difficult to know at the bedside, inoculum effect. So I think the best way to answer this is to have thousands of patients like this and give 500 patient piptase and 500 meropenem and see what happens, right? And that, because this was a problem, it was vexing the people around the world. So one of the ways, one can go by biological rationale and physiology, but at the end of the day, you have to put it to test, because we don't know much about medicine. So until and unless we test it in the patient, we'll never know. So basically, the guideline, this is based on this study, the piptase versus meropenem on 30-day mortality for patient with E. coli like our patient, or Klebsiella, that is Enterobacteriaceae. They have chosen bloodstream infection and resistant to ceftriaxone, that is ESBL. It definitely favors meropenem than piperacillin tazobactam. So the guideline says, these are the recent guidelines which have been published, 2022, world experts have got together. So any of the carbapenem are preferred for pyelo and complicated urinary tract infection. Unfortunately, we don't have sensitivities to Cipro, Levo, or trimeth sulfa, but these are the ones which are equally good for these kind of an infection. So if you are lucky enough to have these as sensitive, even with ESBL Enterobacteriaceae, we can use this. But in our country, because of the cross resistance, most of our bugs also have resistance to quinolones and probably to trimeth sulfa. So the question is, why is that? Why the piptase is not working? Why the outcome with meropenem is better even when piptase is sensitive? So before I answer that, let me ask you, say we don't wait for culture results to start antibiotics. Now, if that patient was started on piptase and he clinically responded, a patient with pyelo having fever, you started piptase, fever is coming down, patient is getting better, and ultimately it came out that this patient had an ESBL E. coli. Would you change your antibiotic? Because the big study, this is called Merino study, showed that carbapenem has got better results. So what would you do? Any thoughts? You have started piptase, patient has responded. Would you now change, or as per study, switch to carbapenem?
No change, no change.
No change. Why? The study had shown that meropenem, there is less mortality with meropenem. There is more microbiological success with meropenem. Sometimes what happens when you start an antibiotic, the patient initially responds, but the later they fail. So that's why whether one should continue with piptase, but now that we know, yes, we started empirically, looks like piptase is working, but 5th day, if he again spikes a temperature, that means it was a partial response only. So what are the guidelines saying on this? If you have started empirically, which was later identified to ESBL, no change, quite right, no change or extension of antibiotic, so you don't prolong the antibiotic or no change. Now why? What is the reason? This is the reason for this. You see what happened in the Merino study, the study that we talked about, they went back and looked at all the isolates and did a gold standard test by broth microdilution or e-test, and they found that many of the isolates which were reported as sensitive by the standard method were resistant by the gold standard method. And that's why carbapenem, meropenem was better than piptase. But for the isolates which were sensitive, even by gold standard method, then there was no difference between piperacillin, tazo, and meropenem. So that was the post hoc analysis of Merino study. So since we don't have gold standard method and a patient has responding to piperacillin, tazo, we hope that this patient's bug is sensitive to piperacillin, tazo, because many of these piptase sensitive by the standard nomenclature might not be in an ESBL. In an ESBL Enterobacteriaceae, if you get a sensitive piptase, then there is a chance that 60 to 70% of them might be resistant. But you are lucky if you have started piptase, patient is responding, so one might be lucky to have a sensitive piptase. So that is the main message, that yes, if a patient, better to go for carbapenem, but remember these are pyelonephritis and sometimes complicated UTI. So basically what are the, let me ask you something else before we go. Let me ask you this one. 60-year-old male admitted with pneumonia. He is hemodynamically stable. Now he has got Klebsiella. Ceftriaxone resistant, again the same kind of sensitivity, piptase and meropenem. Meropenem sensitive, piptase sensitive. So what antibiotic would you choose in this patient? And if I tell you this is true sensitivity, this is true sensitivity by gold standard, or we think that this is sensitive bacteria, what would you choose? This is non-urinary tract infection. Any thoughts? Now you have pneumonia with cephalosporin resistant Klebsiella, very common. We see it almost on a daily basis. What would you choose? Shagnik or Priyanka, they participated previously. Any thoughts?
Sir, tazo and piperacillin.
You see, that's the issue here. The guideline says piptase, the reason piptase is still recommended in urinary tract infections because they concentrate in the urinary tract. Piptase does not concentrate in the respiratory tracts, GI tracts, biliary tracts. So you should not rely on piptase if you have a cephalosporin resistant Enterobacteriaceae. even if susceptibility to piptase is demonstrated, you have to go for carbapenem. So outside the urinary tract, the reason we still go by piptase in the urinary tract, if it is sensitive by gold standard, because there are the piptase concentrates in the urinary tract. You get a much higher level of piperacillin tazobactam in the urinary tract. So basically, what are the points to be considered while choosing piptase versus carbapenem? First of all, as I mentioned, is it pyelonephritis? In a cystitis, in a pyelonephritis, you might want to go more for carbapenem. In a cystitis, if it is piptase sensitive, you might get away with that. For non-urinary tract, there is a very strong recommendation to start carbapenem. It depends on severity of infection. Very severe infection, you give carbapenem. In bacteremia, you give carbapenem. If piptase MICs are on the higher side, but still in the sensitive range, you should still opt for carbapenem. Now, few words which I have seen in clinical practice, many people are using these therapies. So just a few words on before we wrap up ESBL Enterobacteriaceae. This is might not be in ICU, but many a times we do prescribe these. Nitrofurantoin and oral phosphomycin do not achieve adequate concentration in renal parenchyma, should not be used for pyelonephritis and complicated UTI. Now, prostatitis is one of a big problem that we face. If one has ESBL E. coli, sometimes the sort of antibiogram that we get is only sensitive to phosphomycin, and probably all the other are injectable. So if you have only this option for prostatitis, what I would ask you to look at the dose. This is much higher doses than we normally give. It can give rise to diarrhea, but this is what is being recommended. 3 grams daily for 1 week, followed by 3 grams every 48 hours for 6 to 12 weeks. It is associated with 82% of cure. So it is possible, not many people would tolerate this kind of doses, but this was the treatment for prostatitis. And it has been said that you should not use phosphomycin apart from E. coli. You see, we get a lot of Klebsiella sensitive to phosphomycin, and then we use it, but by and large, because of some resistance mechanism, phosphor should be avoided apart from Klebsiella. Okay, so this is what is been recommended. And another practice point which I would demonstrate is doxycycline. I've seen being written for urosepsis is not recommended, because sometimes we find that ESBLs are sensitive to dox, but it doesn't work in the urinary tract infection due to limited urinary excretion. So that is, we have covered ESBL Enterobacteriaceae, and both urinary tract and non-urinary tract. By and large, it looks like carbapenems are the drug of choice, except that you have started piperacillin tazobactam empirically, and patient have responded, and the patient have a pyelonephritis or a urinary tract infection, you can continue with piperacillin tazobactam. Otherwise, if you have a cephalosporin resistant Enterobacteriaceae, E. coli or Klebsiella, if a patient has pneumonia, then it is prudent probably to change to carbapenem. Certain final thoughts. Should we be testing piptase by gold standard? You know, nowadays e-test strips are available in market. So if we have this kind of discrepancy, this will tell us whether that bug that we are growing is truly sensitive or it is resistant. If it is truly sensitive by e-test, one can get away. So the carbapenem load is decreased. Many of these have an OXA enzyme with CTXM. This is not OXA48. These are other OXA enzymes. And that's why piptase is resistant by e-test. But nowadays, we can test for various oxyenzymes by different genotypic gadgets. Another thought which came out is, okay, can we start with few days of carbapenem, get the bacterial load down, and then switch to piptase because it is found to be sensitive. It has not been tested, but it is just a thought that yes, we know carbapenem is superior, but do we have to give this entire course of antibiotic with carbapenem, or it can be switched later? So that is something which needs to be discussed about. So these are my final thoughts on ESBL Enterobacteriaceae. Please write down your questions. Professor Vibhuti Shah is going to moderate at the end of my discussion. We can discuss on different options for ESBL Enterobacteriaceae. Okay. So now we have this patient, 70-year-old male, diabetic, with renal calculi, is admitted with pyelonephritis. The blood and urinary culture is growing Klebsiella. Piptase is resistant, carbapenem is resistant, but marrow is sensitive. As you know, colistin, we don't have sensitivity, just intermediate. So now we have this bug with this kind of sensitivity. It is found, I have seen quite a few patients with this kind of report. Would you call it carba-resistant Enterobacteriaceae? This is Klebsiella. It is resistant to Alta, but sensitive to meropenem. Is it a carba-resistant bacteria or is it carba-sensitive bacteria? Any thoughts? Dr. Shagnik, anybody else? If other people can participate. What it would be? Will you call it carba-resistant or sensitive? What are the recommendations for this? This is a tricky situation, but we do get it many times. You see, as per the definition, any one carbapenem resistance is CRE, that is carba-resistant Enterobacteriaceae. Or by genotyping testing, which I have mentioned, quite a few tests are available. If we find that this bug is producing carbapenemases, in spite of their sensitivity, it is carba-resistant Enterobacteriaceae. Because by the methods that we are adopting now, if a bug is making carbapenemase, sometimes they can show sensitivity by the present method of Vitek or disc diffusion, but we need a gold standard. So that's why if one can do the carbapenemase test, and if it is positive, it is carba-resistant. So this bug is we'll call it CRE. The reason is because the antibiotic choice and all will depend on this. So if this is CRE, which antibiotic would you choose for this patient now? Eta bolo, ekjon keu bolo, eta very important. Which antibiotic would you choose? Patient has ATA-resistant, marrow-sensitive.
Sir, then we can choose meropenem.
Even if it is CRE.
I think colistin, sir.
We just defined this as CRE.
Okay.
So why do you want?
We can give a trial with colistin, sir.
Colistin, we are getting away. Colistin is only intermediate, remember. There is no sensitivity to colistin. It's very important, very important. These are the
quinolones.
Quinolones are resistant. Somebody which is piptase resistant, alta resistant, very, very unlikely that they will be quinolone sensitive. So most of you are going for colistin, it looks like, right? Let's see what's the recommendations are. Very important. You have to go to the bedside, you look at the antibiogram and take a call. You can get away with a high dose extended infusion meropenem. If it is an ARTA sensitive, resistant, but marrow-sensitive. You do not have to go for colistin or for other antibiotics, provided your carbapenemase is not available or negative. If you have a carbapenemase positivity, which we do not know in this patient, we don't know in this patient, then you can't give meropenem. If you don't have this enzyme, then you can go for meropenem, that is 2 gram 8 hourly, infused over 3 hours. This is what is high dose extended infusion meropenem, provided your creatinine clearance is normal. So these are the different doses of meropenem and infusion time, which is being recommended. For most of this ESBL carba-resistant enterobacteriaceae, 2 gram over 8 hours, 2 gram 8 hourly infused over 3. Sometimes we give it over 4 hours. In the others, like cystitis and other enterobacteriaceae, you can give it over 30 minutes. The standard infusion, 1 gram 8 hourly. But for carba-resistant enterobacteriaceae, you have to give 2 grams every 8 hours infused over 3 hours. So you do not have to go for colistin, which has got its own toxicity. If you have a marrow-sensitive, but if you have a carbapenemase production, then you might have to go for the other antibiotics. Another way to choose the meropenem dose is this of this nomogram. Now, as we know, the meropenem dose will vary depending upon the creatinine clearance. You have the different meropenem dosing per day. You have the creatinine clearance. And here you have a level of meropenem. So, for example, if the meropenem MIC is 2, then we want 4 times the MIC. I want 8 milligram as my blood level of meropenem. And if my GFR is 100, I can get away with 2 grams of meropenem. And that's how, this is how this works. And that is, so one can choose the different doses of meropenem depending upon what is your projected drug levels you want. And this can be predicted by the MIC. You have your GFR, and then you have an extended infusion. So this entire dose can be given over 24 hours. So another approach, PKPD approach of giving meropenem. So the question comes, in this case, where it is ERTA-resistant, marrow-sensitive, would you check for carbapenemase production? Ideally, yes, because if it is carbapenemase producing, then carbapenem is not going to work, because meropenem should be avoided if carbapenemase testing is positive, even if susceptibility to meropenem is demonstrated. So you see, nowadays there are many gadgets which will tell you whether the culture which is growing. So sometimes when we have an antibiogram, meropenem sensitive, patient is getting meropenem, not responding, yes, we should look for other things, but at the same time, we should ask our microbiology to do a carba test in this patient, because if it is carbapenemase, it might be sensitive, but it is not going to work. So it's very important carbapenemase production should be, because the MICs, the calculation of MIC by the standard method, if a bug is carbapenemase producing, is rather confusing, and this Vitex and all, they might report it sensitive. What are the preferred antibiotic for treatment of infections outside of the urinary tract? Again, you see, we have to define urinary infection and non-urinary tract infection. Again, if you have a bug which is resistant to ERTA, but susceptible to meropenem, then what should be done? This is the treatment. You have to give high dose extended infusion meropenem outside the urinary tract. So basically, if you have a CRE, But marrow is sensitive. You can try high dose extended infusion, but what you have to do is look for carbapenemase enzymes. Okay, so now let's come to this patient. A 50-year-old female, diabetic with impaired renal function, had previous hospital admissions, admitted with lobar pneumonia. The sputum and blood culture grows Klebsiella. This is piptase resistant, ARTA resistant, marrow resistant, only sensitive to tigecycline and colistin, which is intermediate. So which antibiotic would you choose in this patient? Any thoughts? Any thoughts from postgraduates? Which antibiotic would you choose in this patient? It is definitely resistant to marrow, ARTA, piptase. Ki Dr. Shagne, ki debe? Dr. Priyanka, which one would you go for? Colistin?
Yes, sir.
Okay. Any other choices?
Rucha, will you like to comment?
Orithro. Dr. Orithro, bolo. Orithro ki debe?
Sir, can we have any trial of fluoroquinolone?
Quinolones will be resistant. You know, someone having a piptase, ARTA. I have not given all the antibiotics, but the chances are so high they will be resistant, especially in our country. So what you have to do, so this is, what kind of resistance mechanism will this have? What do you think? CTXM, NDM, OXA, or AMC. These are the four that I showed. AMC are sensitive to marrow. AMC are sensitive to marrow, resistant to cephalosporin and piptase. CTXM resistant to cephalosporin, but sensitive to piptase and carba. These two are resistant to carbapenem, NDM or OXA. So our bug will have one of those two. Either it is an NDM or it is an OXA, one of those two. Okay, so remember, if you get an antibiogram by phenotype, you can almost predict the genotype, but you do not know from phenotype whether it is NDM or whether it is OXA. And that's where your antibiotic choice will depend. Yes, Dr. Teja. Yeah, you want to say something? Somebody wants...
unmute.
If it is NDM, we could use ceftazidime, avibactam, and azithromycin combination.
Right. And if it is OXA?
If it is OXA, we could plainly use ceftazidime, avibactam.
Avibactam.
No need of
any. Another thing, you see, what is the MIC of this patient's marrow is 4.
Marrow is MIC is 4, so we could use high dose meropenem also in this patient in combination.
If you have 16, you want 4 times the MIC, 16. Something like this, with depending upon your GFR, you have calculated the dose, but that is not very much recommended.
Yes,
Ceftazidime, as you mentioned, in combination with aztreonam. Why in combination with aztreonam? What is...
The metallo-beta-lactams could not be eliminated with ceftazidime, so we have to give azithromycin.
Why not just aztreonam?
Yes, sir. And avibactam for BLI.
Why not just aztreonam?
Plain azithromycin will not work, sir, because lactase inhibitor is not there. So we have to give with combination of avibactam. Azithro and avibactam combination is not there. So we give ceftazidime avibactam in combination of azithromycin.
Right, because aztreonam will be hydrolyzed by beta-lactamase, this ESBL. So that's why you require an avibactam. So ceftazidime in combination with aztreonam, if you have an NDM, Enterobacteriaceae, remember, this might not work for Acinetobacter. If you have an Enterobacteriaceae, then this will work. But if you have an oxa only, you just ceftaz-avibactam would work. And there is no way, by looking at this phenotype, you can predict that. So you have to do some kind of a genotypic test. They're not that costly. You get the result in few hours, and we should be able to say whether it is an oxa or whether it is an NTM. So that is what is, we are going towards individualization of our antibiotic choice. Just a few words on ceftaz-avi. Now, as you know, it's a new drug in the market. Now it will be flooding the market very soon. The emergence of resistance is a concern with all the novel beta-lactam. There are quite a few. In our country, it's only ceftaz-avi is available. But the frequency of this resistance appears to be the highest for ceftaz-avi. We have already started seeing a few resistant to ceftaz-avi. So very judicious use of ceftaz-avi should be done in our country. So we should be looking for oxas, NDMs, and then only use ceftaz-avi. Now, as you could see, this patient was sensitive to TG cycline. So why can't we use TG cycline in this patient? Any thoughts? Why not TG? Why not TG cycline? That's also an option in this patient. Why not use it? You see, the tetracyclines are not recommended as monotherapy for treat. They can be given as a part of combination because, first of all, they do not concentrate in the urinary tract, as we mentioned, even that doxycycline, or bloodstream infection. The bloodstream, especially TG cycline, they are very small molecules, so they dissipate. They do not stay in the bloodstream for long. So bloodstream infection, urinary tract infection do not rely on tetracycline derivatives. Polymyxin B and colistin should be avoided for the treatment of infections caused by CRE. You can use colistin in an uncomplicated cystitis. You cannot use polymyxin because they are not excreted in the urine. So by and large, the world literature wants to avoid polymyxin B and colistin. Sometimes we do not have any choices, so we have to go for these antibiotics, but that the recommendation is to avoid polymyxin B and colistin. Now, what about combination antibiotic? Use of beta-lactam agents, that is, you can use ceftaz-avi along with polymyxin and all, is not routinely recommended for the treatment of infections caused by CRE. So combination is not recommended. Okay, so let's have this case, a 40-year female. So basically for CREs, what we need to do, for carbaresistant Enterobacteriaceae, high-dose meropenem is an option, but it is not recommended. It is either ceftaz-avi alone or ceftaz-avi with aztreonam if it is NDM. Colistin can be used in combination, but very rarely. Now coming to this very important bug, which we face every day, 40-year-old female admitted with alveolar hemorrhage, secondary to vasculitis, treated with high-dose steroid and rituximab, developed severe hypoxia and lung infiltrate. ET suction and blood culture grew Acinetobacter. It is resistant to all except colistin, to which it is intermediate. Meropenem MIC is 16, Amsulv MIC is not done. So what do you think? Which antibiotic? Yes, Dr. Rucha.
Hello.
Yes.
Sir, we can use high-dose sulbactam in this patient.
High-dose sulbactam. Why is that? It is
because it is recommended in Acinetobacter infection that high-dose sulbactam is work. Sulbactam is basically for Acinetobacter infection.
If I tell you if it is AMSUL resistance, then what will you do? If it came out to be resistant to AMSUL? Yes, Dr. Teja. What will you prescribe if it is resistant to AMSUL?
Sir, even if it is resistant to AMSUL, we can use high-dose sulbactam with combination of minocycline. Sir.
High dose, why not TG cycline?
TG cycline doesn't concentrate in the lung, so we use minocycline as an alternative.
Okay. Anybody else? First of all, would you use a single, double, or triple therapy in this patient?
Sir, single therapy is not that much recommended. We use double or triple therapy for the resistant Acinetobacter.
So let's see what the recommendation is. First of all, the thing about Acinetobacter, since the blood culture grew Aceneto, that's why it has become very important. If it was only ET suction growing Aceneto, the first thing about Aceneto is it a colonizer or is it a pathogen? Aceneto is everywhere. It is in water, it is everywhere. So just getting an Aceneto does not mean it is an infective pathogen. Yes, if you grow in blood, even in blood, we have found sometimes it is contaminant. So make sure that the growth is heavy growth and you think that is the culprit. So that's the first thing about Acinetobacter. Now, once you grow, the second thing is what is the severity of infection? Is it mild or is it severe? In mild infection, you can get away with a monotherapy. And the panel suggests, this this infectious disease expert suggests AMSUL as the preferred agent for this. And in patients with moderate to severe, combination therapy of 2 agents with in vitro activity when possible. Many patients, the antibiogram should show sensitivity to those antibiotics. So it is very important that we need to look into the antibiogram. So high dose AMSUL. Why is sulbactam so important for Aceneto? Anybody? Because we don't use sulbactam for any other infection. Then why Aceneto? Dr. Teja, why Aceneto? Why sulbactam? Yeah, Dr. Ruchi?
Sir, this sulbactam has extra OXA23 action.
Okay, Teja?
Sir, Acinetobacter main action is not of carbapenemase, but via efflux pumps and porin channels. So sulbactam could act in those cases.
But efflux and porin have mutations are very important in others as well, but we don't use sulbactam for those. Like imipenem has porin, Mero has efflux. We never use sulbactam for those. Any other thoughts? So it's not porin, it is not efflux, it's not oxa. You see, the Acinetobacter gets mutation due to various mechanisms. It is NDM, there are various oxas, but one most important mechanism by which Aceneto becomes resistant is there is a mutation in the cell wall of Acinetobacter, what is called PPB2 mutation, penicillin binding protein 2. And the sulbactam works on that. And that is why sulbactam is very important for Acinetobacter because of that PPB mutation in the cell wall. But we recently heard from an infectious disease expert that there are a lot of work being done in India, which is showing that Acinetobacter has a particular oxa to which sulbactam doesn't work. In fact, they were claiming, works done from Vellore and other places, that most of the Acinetobacter in our country have that oxa enzyme to which sulbactam is resistant. So, which I was not aware of, But that is something you need to look into. If you have a patient, as per this recommendation, you are giving high dose sulbactam and avoiding, say, colistin, patient is not improving, think of that, because of the work done in various labs in India are showing that there are certain oxa enzymes which are very prevalent in Indian Acinetobacter, to which sulbactam doesn't work. This is the international recommendation because most of the Acinetobacter grown elsewhere are showing just this cell wall mutation to which the sulbactam works. So that's why very high recommendation for high dose sulbactam, even if it is resistant by antibiogram. So it is very important that high dose sulbactam can be used, but look for a response to high dose. One can use minocycline and polymyxin B in combination with the sulbactam. And high dose is how much? 8 grams of sulbactam per day. We are lucky to have sulbactam, but places which do not have sulbactam have to use very high dose of penicillin. So they usually avoid it. So 8 grams of sulbactam per day. And we just discussed for Acinetobacter, we prefer minocycline. For Klebsiella, TG cycline is usually given, but not for bloodstream or urinary tract infection. It can be given for pulmonary infections, especially if it is Klebsiella in combination. Now, high dose, if you have to give minocycline in this patient, you have to give high dose of minocycline, which can cause a lot of GI problems. So for this kind of multi-drug resistant infection, if one has to choose mino or TG cycline, one has to give a high dose. TG 200 first dose, then 112 hourly, and minocycline 212 hourly. And if it is sensitive to mino, does not mean it will be sensitive to TG, because there are cross resistance to these as well. And there is very high degree of GI disturbances in these patients. Now, where do we stand with polymyxin and colistin? Polymyxin can be considered as monotherapy for mild crab infections and in combination with other, especially in our country with this oxa thing coming up for sulbactam. It looks like that we might, because I have not been using poly or colistin lately for Acinetobacter, but after listening to that oxa thing, I will have to look very carefully whether my patient is responding to high dose sulbactam or not. Now, you require high dose of colistin, which gives nephrotoxicity, and polymyxins and colistin, the epithelial, the lung penetration is very poor. And that's why for pneumonia, they are not a very good drug. It's very important to know this. Now, what is the role of extended infusion marrow, high dose marrow for crab? It can be used as a combination therapy, poly, marrow, minocycline, but not as a standalone. That is for sure. You cannot use high dose marrow, but people are using colistin or polymyxin with a high dose. So triple combination therapy with meropenem, Amsulb, and minocycline. It looks like high dose marrow extended infusion, high dose sulbactam and minocycline, or probably polymyxin with high dose meropenem and minocycline as a triple therapy in patient with very severe Acinetobacter, which you think is a pathogen, is not a colonizer. What is the role of nebulized antibiotics for Acinetobacter? Any suggestion? What are the recommendations for nebulized antibiotics? Anything? Any suggestions? Yes, Dr. Gupta, Vishal Gupta. What do you think? You see, we do give a lot of nebulized antibiotic, but
the nebulized antibiotic, I think it is not recommended because it gives to unequal distribution of the drugs, and it produced some adverse reactions in the lung, maybe bronchoconstriction, and I don't think that the nebulized antibiotic in the case of SI2 will work.
You know, at one time, because we didn't had many systemic drugs, we used to use a lot of nebulized colistin for Acinetobacter, even with the right jet nebulizers and all. But in spite of that, the experts do not suggest, because the outcome studies have not shown that nebulized antibiotics has an edge over just systemic therapy. Now, this new kid on the block called cefiderocol, which will soon be there in the market in India. So I think you should be aware of this new drug. So is there any role of cefiderocol? What do you think? For Acinetobacter infection. Any thoughts from participants? Now, what is this cefiderocol? This is a Trojan horse antibiotic. This is available in the name of Fitroza in the gray market. Why this Trojan horse? They have chosen this symbol with a meaning. Yeah, Dr. Rucha?
Sir, it uses ion channel in the bacteria to get inside the organism, and then it act on the organism. So particularly this gene resistant pattern is not for this antibiotic, because it doesn't act on any protein or this or bacterial cell or membrane. It uses the ion channel.
True. The reason it's, you see, the periplasmic space is where the beta-lactamases circulate. And if your iron channel will bypass it. So basically they are not exposed to beta-lactamases in the periplasmic space. So this is a cephalosporin which will gain direct entry into the cell of the bacteria through iron channels, because bacteria needs iron to multiply. And as you know, we don't give iron in severe infections. But after getting into the bacteria, they kill the bacteria. So that's the Trojan horse policy. But unfortunately, the hype with which it came has not been fulfilled in the many clinical trials. In fact, in one of the studies, cefiderocol had a higher mortality than the standard therapy. So they say it should be limited to treatment of CRAB, refractory to other antibiotics, intolerance to other agents, but more and more studies are coming where it is not found to be that effective. So I think it's very important we should keep this in mind. Okay, so Vibhuti, where do we stand? Do you want me to continue or moderate? Where do we stand now?
I think you can do with this case because you are doing introduction, so that's a nice way of going ahead. You can do this case. Please go ahead with this case.
I have few cases, 1 or 2 cases based on genotype, you know. I think it's important for the participants now that we have access to these genotypes to have. Is that okay, Vibhuti?
Yes, yes, please.
Please. Okay. So a 50-year-old man on maintenance hemodialysis, he had a pump cath for 3 months. He was admitted with septic shock, probably secondary to line sepsis. And as usual, because we think of gram-negative, gram-positive in a line sepsis, patient was started on vancomycin and meropenem. The lines were changed, blood cultures were sent. Next day, patient still febrile on mero and vanco. The pump cath line is out. The cultures are not yet available. Inflammatory markers are very high. Patient is unstable. Would you change antibiotics at this point? Anyone? Dr. Teja, what will you do? Will you change? What
Sir,
is your... Yeah.
Patient is like central and associated bloodstream infection. So Vanco and Miro are the choice of empirical coverage.
Yeah.
But patient is hemodynamically unstable and still having persistent fever. So we would like to change the antibiotic. But
what would you change to?
What we should change to?
Change to what?
Sir, before changing antibiotic, we should actually know the vancomycin MIC if it is available, if blood cultures are available in Bactec, and we should know that.
Failure patient, it will be very unlikely you will underdose vancomycin in these patients. So hopefully it is adequate. Anything else? Would you change meropenemate? I've seen others raising hands. Yes, please.
Sir, we should not change antibiotics for this patient because antibiotics will need at least 48 hours to work.
Okay. So if he's the same next day?
Then we can think of changing the antibiotics.
To what?
Sir, it could be a vancomycin resistant enterococci, which is most common pump cath related infection. So we could give linezolid or daptomycin, as we have to give cover for VRE.
Okay. So
vancomycin resistant enterococci.
I think it's a well thought of. Yes, you can use dapto.
Yes, sir.
What about mero-resistant gram-negative? There are many mero-resistant gram-negatives as well, isn't it? So one can think of that as well. So resistance to mero and vanc. Patient had a colistin added to mero and vanc continued, but I would agree if you want to change to dapto, that can be done. Patient still febrile, still unwell. Gram-negative bacilli is now growing. So vanc was stopped. Colistin and mero was continued. Patient still febrile on high dose of vasopressors. What would you do?
Sir, we would order a carbapenem resistant testing to see
Patient
if
is
it is
on colistin.
Colistin in bloodstream infection, it may not be working.
You have any other option? You have given colistin. Yes, Dr. Rucha.
Sir, can it be a NDM? We can suspect a possibility of NDM in this patient. So we can try adding aztreonam.
Aztreonam. Okay. Aztreonam with colistin mero, how much will it add further? You have given colistin and mero, you got an infection, blood culture growing gram-negative. Let me tell you, this is a real case, and we are getting these kind of patients. And you have taken out the line. Yeah, any other thoughts?
Sir, could we change to polymyxin B rather than colistin? As bloodstream infection, polymyxin B is a good choice rather than colistin.
Well, there is some difference in nephrotoxicity, but if you are dosing good enough, then these two are okay. Polymyxin does for urinary tract, yes, but for line sepsis, there should not be too much of a difference. So polymyxin, mero, anything, and anybody else would choose anything else? Okay, yeah, Dr. Gupta.
So patient is on was on hemodialysis, so it could be possible that the rare environmental bacteria can be grown in the blood culture. Gram-negative bacilli does not mean that there is always E. coli or Klebsiella or Acinitos. So it could be that those bacteria which are intrinsically resistant to gram-negative bacteria intrinsically resistant to colistin. So that's why that was the identification of the gram-negative bacilli is, I think, necessary.
So which antibiotic would you choose? At the end of the day, you have to choose.
It has been done given to as a empirical, but
you have to give empirical. I'll just take time. Any other? You are almost on the right track, but which antibiotic could you choose? Okay, I will give you another clue. Blood culture, this was the blood culture report in this patient. No enterococci, no staph, no strep, no acinetobacter, no pseudo, no E. coli, no Klebsiella, no Candida.
It could be Stenotrohomonas also. I don't think so. Stenotrohomonas, because I don't think that Stenotrohomonas is in the biofire list.
No, it is not. Then what will you give? Bactrim in this way. You can.
Yeah, bacteria, yes. Or cotrimoxazole can be added, but I think the identification of the bugs is important here.
You got the multiplex, but identification takes time. Huh?
Yes.
So now if you have a negative multiplex PCR, these are the bacteria which are covered. So the blood culture report came and it was Chrysobacterium.
Okay.
As you were mentioning, nowadays we are getting Burkholderia, Chrysobacterium, Elizabeth Kinglia. These are the organisms which are waterborne. They contaminate water. And our water hygiene is unfortunately not very good in many of our ICUs. And we do get contaminants, especially hemodialysis patients. And these are not there in the multiplex PCR panels. And they are intrinsically resistant to colistin. They do not respond to carbapenems. They are gram-negative bacteria. So they are usually sensitive to minocycline. So nowadays, minocycline is gradually coming to our even empirical choice of dialysis catheter infection. And if we grow a bug, if we blood culture is positive and biofire multiplex is negative, the chances are very high it is a minocycline sensitive bacteria. So we should keep this in mind. If you have a persistent fever in a patient with colistin and meropenem and vancomycin, Stenotropomonas is a good idea, but bloodstream infections are very rare. You can get pulmonary infections. So keep in mind minocycline for these patients. It's very important. They are the ones which can cause a lot of, so they are resistant to colistin and mero, and patient responded to IV minocycline. In fact, we did a study, one of our DNB students, we found, as you mentioned, even steno is sensitive to mino 100%. So even if you think of Stenotrophomonas, Burkholderia, Sphingomonas, Chrysobacterium, Elizabeth Kinglia, these are all waterborne. These are the ones that can be treated with minocycline. Okay, so I will end here and hand it over to Vibhuti for further moderation. Vibhuti, over to you.
Yes, we had a nice interactive session from Dr. Todi. So any remaining questions, anyone from anyone? Please type the question in the chat box so that Dr. Todi can answer to them. Before anyone puts in a question, I have I want a suggestion from Dr. Todi. In fact, you know that you have highlighted very important issues, and in most of the government hospitals and budding few hospitals like you or Apollo or something like that, they don't have this genotypic translation facilities. So I understand that we should have one, but it's a question of government policy for having that. So otherwise, the choice becomes empirical, as you have been discussing with the cases. So what is your suggestion regarding this?
First of all, I think having a knowledge, having a background knowledge of this problem exists. And I have an antibiogram which is, say, sensitive to mero. and I have a meropenem, I have given meropenem to a patient and patient is not responding. I have excluded other reasons of non-responders. I have to be cognizant of the fact that I don't have genotyping facilities, but there is a possibility. It is showing merosensitive in the Vitek or in the standard labs, but probably it is a mero-resistant organism. So it's either an OXA or an NDM, and probably I would start ceftazidime and aztreonam in that patient, or if not possible, give colistin to that patient, which we normally do. You know, unknowingly we do it if patient is not responding to carba. Even if it is a carba sensitive bug, we give colistin to that patient. So by and large, you know, from the other way around, we do what we would have done if we had a genotype. You get my point? So I think that is how things are going. But nowadays, this carba card tests, this carba NP tests and all has become very cheap. And I know the labs can do it indigenously at a very low cost as well. So if the workload is not too high, only for selected group of patients where there is severe infection, patient is not responding to so-called appropriate antibiotics as per antibiogram, some more information from microbiology would be helpful.
So let me see if there are any questions.
Let's see, chat. Hospital policy, yes, there should be. Policy should be there in all the hospitals. Carba-resistant acinito, often found E. coli in urine with significant colonization. Patient is asymptomatic. What to do? You know, it depends whether the patient is catheterized or not. If the patient is catheterized and patient doesn't have any fever or anything, you just have to either change the catheter, take the catheter out, don't have to treat that E. coli, and always see whether there is a lot of pyuria along with that. But if a patient has high fever with E. coli in the urine with or without catheter, then you have to treat it. But in an asymptomatic, try to see whether there is a residual urine there or not. In a female patient, get a gynae examination. And so look for those things rather than just treating with antibiotics. There was some...
Shanto Shubro has a question. Shanto Shubro.
Yeah. Yeah, Shanto Shubro, bolo.
Hello.
Bolo.
Yes, sir. I don't have too much of a question, but I should definitely congratulate sir for this brilliant discussion on MDRs. The problem with our institute is we don't have those genotype tests, and we frequently get patients suffering from MDR infections, and we land in nowhere actually. So I would ask Dr. Todi is, when we get very sick patients from community with a very bad hemodynamics, what empirical therapy you prefer us to start with before getting those pending culture results?
You have to individualize. Each patient is different. Each patient. I cannot give you an empirical therapy regime which you can go and apply to your patient. So what are the three things that you need to see in your patient to decide? First, you have to see what kind of patient is this. Is it an elderly patient, multiple comorbidities, previous hospital admissions, previous antibiotic exposure? So that is the first history that you should take. In a patient who might be in severe shock, but if a patient has been otherwise young, healthy, has come to you with a pneumonia, even if he is in severe shock, the chances are high this could be a pneumococcal pneumonia. This is very deadly bug. They can get away with ceftriaxone only. So it's very important you look at the patient. So if a patient has a lot of comorbidities, you have to cover for MDR, you might have to go for higher end antibiotics. Second, you have to see where is the infection? Is it the lung, whether it is a urinary tract, whether it is an abdomen, biliary? So depending upon the site of infection, you have to have an educated guess of what kind of bacteria it could be. For example, in a urinary tract, we don't think of Acinetobacter. In a pulmonary infection, patient previously hospitalized, you might have to think of even Acinetobacter. And third is the previous antibiotic exposure. If a patient has already been exposed to piperacillin, tazobactams, or carbapenems, then you have to use an alternative. So previous antibiotic use, the site of infection, and the type of patients you have, that will decide on your antibiotic choice rather than the severity of infection. You see, the severity depends upon the host response, doesn't depend upon the bug as such. A very sensitive bug can cause very severe shock. So look into these three and then make a choice of your antibiotic. Okay?
Thank you. Thank you.
Shubhas, someone has asked about EDTA.
I have
Subhash,
never
are you here?
tried. It is there in the market. I have seen people using it. It is an so-called anti-NDM EDTA. I have not tried it, and not much of literature. Unfortunately, the West doesn't have EDTA. They don't need it, so they don't work on it. I do not know. I do not know whether it works or not. There are many drug combinations with EDTA. Now EDTA is available as a standalone drug as well. So just giving EDTA for chelating the zinc and other metals physiologically might make sense, but the dosing of EDTA, which I was told needed, is very high. And so basically, I don't know whether it is an emotional blackmail, you might say, since we don't have any other option. We know EDTA chelates metal, and we have high problem of metallo-beta-lactamase. So somebody came out with this great idea of giving EDTA chelate metals, and then your bugs would be killed, something like that. I do not know. Not much work has been done. Unfortunately, I think our labs, even the postgraduate, the medical college labs and Vellore and all, they should do work on this and publish on this so that we practitioner, because on the other hand, we don't want to throw it away as well. Aceneto is our problem. MDM is our problem. And since we don't have help from the Western world for newer antibiotics on NDM, we have to devise on our own. But then we have to follow the very important methodology to prove it, Like Ceftazidime has come to the market after 10 years of research. And so I don't see any kind of research being done in that way with EDTAs and the others. Unless we do that, just blindly accepting the drug on the basis of physiology, because I am sure it will have side effects. It can't be without side effect. Whether it will chelate some other important things in the body, I'm not sure. Zinc is a very, very important element in many of our enzymes. So if you are giving EDTA, it will chelate zinc. Whether our other enzymes are, it's not going to chelate zinc just in the bacteria. So we have side effects. So,
sir, may I ask you one question?
Yeah.
Sir?
Yeah.
Suppose.
Yeah.
Sir, your comment on duration of antibiotic therapy, particularly in cases of osteomyelitis or necrotizing ascites. So we need to give a longer duration of therapy. So how do you actually determine 2 weeks or 3 weeks at least?
By most of this antibiotic duration has been shortened now. These are even for patients with abdominal sepsis, peritonitis, bacteremias, pneumonia.
7 to 10 days.
Even less. there is a stop it therapy of abdominal sepsis post-operative 4 days. But unfortunately, most of these trials were done on sensitive bugs. Then 4 days is good enough if you have a very sensitive antibiotic. Not much data on MDR infections. In fact, most of these studies where they gave antibiotics short duration for MDR had a relapse. So again, we don't have much idea, but I think we have to use judiciously clinical response and biochemical response with CRPs and if possible procalcitonin. But for osteomyelitis, endocarditis, and other infection, it is a very long duration. We fully agree. Right. And there are established guidelines on that. But most of the ICU-related infections, I think we should decrease our duration, not to the extent as been said in the West of 4 days, 5 days, especially in MDR. But I think we should go by clinical response. And if the CRP has come down by 80% from the baseline, even if a patient has a high white count, even if a patient is running a little temperature, but if the patient is overall okay, we have a sensitive antibiotic and CRP has come down by 80%, even if it is on 4th day, we can stop antibiotic. I think we give a rather long duration of antibiotics when the patient responds.
Thank you.
Thank you, Subhash, for your wonderful presentation. Oh, Vishal has a Vishal, do you want to say something? Vishal.
Hello, sir. What is the current status of antibiotic lock therapy?
Antibiotic locks, like in maintenance hemodialysis, is sometimes given, but I have not seen it being used a lot. The reason is, whatever antibiotic you use for the lock, the bugs are going to get resistant with that. So the new thing which has come in is this antibiotic alcohol therapy. You see, medicinal lock with alcohol-based solution rather than antibiotic solution. It is in its infancy, but sometimes if you have a line which cannot be removed and you are sure patient has line-induced bacteremia all the time, it's say if it is a pump cath, you can't remove, patient have no other access. So depending upon what bug you are culturing, you can give even colistin, you can give vancomycin, you can give aminoglycoside in that line as a lock therapy. So it is doable, but in a very specific situation.
So I think we had a wonderful talk from Dr. Subhash Todi and wonderful, nice discussions, interactions. Thank you, Subhash, very much. I hand over the mic to Apurvoda. Are you there?
Okay, okay, Vibhuti. Now, thanks to you and Subhash also for this excellent discussion review on resistant antibiotic. Now we have some ritual. The last ritual is giving the vote of thanks. Now I request Dr. Tapas Banerjee, who is the Secretary of API West Bengal branch, to give vote of thanks.
Thank you, sir. Thank you for allowing me to give vote of thanks. On behalf of API West Bengal chapter, I would like to thank Dr. Subhash Todi for a wonderful, extraordinary talk on antibiotic resistance, how to identify antibiotic resistance, how to overcome, what are the panels that we need to bear in mind, and most important, when to send it. I think there will be a lot more questions in the minds of the list and as well as the postgraduate trainees delegates. So let me thank, apart from Dr. Todi, Dr. Vibhuti Shah for nicely moderating this wonderful topic. Also like to thank the faculties, the delegates, the postgraduate trainee students, and last but not least, the sponsor and our office bearer, Kaushik. So with this, I would like to call it a day today. Thank you all.